process. So beginning with the issue, and I think a number of people could probably speak to this, we've heard about a pretty good uptake of electronic medical records from multiple providers within British Columbia. You know, they don't really talk to each other particularly. They're sort of in-office systems. And someone asked, will we ever have a paperless model for health records, a true common portal for that where records can speak to each other, it would work, and something that would be accessible both by the provider and by patients. What do you think, Kendall?
Yeah, so thank you for that question. I think that clearly would be an area where not only do we look at live interprofessional collaboration, provider-centered, patient-centered care, but actually an electronic record that facilitates that. I think we're not there today, but I think in electronic health record in the hospital, we're actually approaching that. And also an individual electronic medical record, having linkage to that will be very helpful. I think it'll be really innovative, especially when patients are able to get access to that record. I know that, in fact, I think Jeremy from PITO was here having some experiments in terms of opening some of those electronic medical records to the patients so that they can have access to it. Again, a huge interest and uptake. But it'll be really interesting if we can have patients to manage their own electronic record so that the patient have actually control of that and then actually distribute that out. I think it'll be wonderful as another model for us to kind of consider in terms of how do we really get there so that as health professionals, we contribute to the patient's record as opposed to the other way around.
That's good. Alan, you talked about the importance of having connectivity in this context between different providers. Do you think you can foresee a future when all our records can talk to each other?
You know, I think that there are two aspects to this. The first one is the actual technology aspect, is getting that data interoperable so that you can move it around and move it around in a meaningful way. So having data interoperability is one thing, but moving all the information where I'm getting extraneous data that I don't need actually can end up becoming more of a problem than it's actually solving. So I think part of it is just making sure we get the data moving. The other part is cultural, and it's very interesting. You know, I watch my staff now working on computers after they've worked in a paper practice environment, and they've got sticky notes. I'm sure you've seen this on computers. You know, there's the post-it notes stuck all around the computer to remind her of various things. So I think that part of it is just the learning curve, but I think we also need to remember that paper can be very useful. So the intent is to have exactly the right tools we need to do the job. And if paper does one or two things well, then we keep those things in paper. And I don't say anything negative about the technology side. I think we've just got to be very careful how we use it.
Michael, you thought it was still within this topic that one of the barriers to this sort of interoperability and communication is the fact we've got at least 10 separate healthcare systems with their own information thing. Do you see prospects for that improving to allow certainly interprovincial systems to talk to each other, much less intra-provincial ones?
Answering this question could get me dangerously close to a commercial for TELUS. But that is a major motivation for why TELUS has moved into this area, because we do see that potential. And we see an opportunity to do something nationally that is still respectful to the governance of health systems at a provincial level, but still get the economies of scale from a national approach to this. The other comment that I'd just like to make on the question is that whoever asked the question, I think, constructed it very well, because they went beyond paperless records and said engage the patient. And Kendall's already commented on that, but I think as we've seen it, because we've been doing a whole series of pilots of giving patients access. Our biggest pilot is actually here in BC. And what we're finding is that even though the patient says, yes, I want access to my records, they're really looking for access to their provider. And they want to be able to discuss those records with the provider. So I think a shared record is great, but making sure that the tools are there for the patient and the provider to be able to interact and discuss the implications of those records is going to be very, very important. And I'm choosing my words very carefully. I'm saying provider rather than physician, because I think that it's going to be pharmacists and dietitians and nurse practitioners who are going to actually handle a lot of the discussions with patients in addition to the physician.
Thank you very much. Still from Dr. Ho's presentation, a question came up. I'm going to actually direct to Lindsay because it's about privacy. Privacy fears loom large in healthcare. It always is raised in IT. And the questioner asked, can governments adapt privacy legislation quickly enough to take advantage of these new technologies, or will privacy laws be a roadblock to modern care? What do you think?
So I think that there's a fallacy around where privacy fears loom large. If we look at the way citizens act and the information that they're willing to share, I often think that the privacy fears are often those fears of advocates. Certainly there are individuals who have conditions that need to have that information protected because they can be subject to discrimination. But I have never met a person who has a severe mental illness or, a severe illness that wouldn't share that information if they thought that they could get care. Really, I know many patients that would take out billboards if someone could help them with their medical information. That being said, privacy is very important. I think the concerns that people have with IT and privacy, that IT is going to make records less secure, are really fallacies. Our ability to audit and monitor electronic files are certainly significant, way more than our ability to audit and monitor paper files. The number of breaches I have because paper files are lost or left on the top of a roof of a car are far greater than I have from IT files being hacked. So I think legislation can change. The legislation we have is working. You can always make legislation better.
So it doesn't sound like privacy is a barrier to technological innovation at all, that the current standards are higher than paper. And other panelists, do you have comments on the privacy issues? Would you agree, Kendall?
I absolutely support what Lindsay said. I think also in some of the international survey, in fact, very interestingly, for countries where there's lower access to health service, privacy become a very low priority, and access to service become a huge opportunities and huge demand for them. I think I also want to feel that elephant in a different way, in that we ourselves need to be educated as smart consumers, because every time you sign up for that app, you yourself have the opportunity to give out privacy issues. For example, you need to figure out when you trade for doing your heart rates, you're going to give out your email, your internet address, your Facebook, your Twitter account. So in some ways, you're giving up something also to trade back onto that benefits. So I think all of us ourselves also need to be vigilant about our own privacy. How do we protect it? And if I give out my email address so that I can actually measure my heart rate, this is a good trade. But in order to get a heart rate, I got to give out my financial information, my address, my kids' names, etc. I'd say, well, no, that's no good. So I think in some ways in eHealth literacy, we also need to understand the privacy issue ourselves as we move forward.
Very good. Richard?
I think it's public perception. If you think back before the days of internet banking and everyone was afraid that our bank accounts would be emptied out, as patients get more access to their files, although theoretically they've always had access to their files, they see what's there, and they become part of it, and it's less of a concern, so I think it's just getting used to the idea of having it there and then knowing it's secure. And it's somewhat of a paradox, actually, that patients will worry about their security, but then they'll email the office a question with a mechanism that has absolutely no security at all. And so there's just the concern that someone's going to look at it, but they'll learn that it's actually very, very safe.
Any other comments on the privacy issues?
I'd just like to make a comment on the email, because even though we've got some secure systems that we could potentially be using for communication, the majority of communication around clinical information is probably still taking place through the public internet. And so we need education, and we also need tools so that we can actually communicate more effectively. There is a private network available in BC that can be leveraged, but this is one of those challenges that we all face, and it's very difficult because if you share your email, even if it's your practice email on the internet, which we've done through our practice and I've done for many years, as long as you put clear guidelines out around what's appropriate, you generally are reasonably protected, even if the patient does share information. And you always remember that you don't have to respond to it. You can always get somebody to call them up and say, look, you've got an issue, please come in, we need to talk to this face-to-face, rather than responding through a public email address. But clearly, privacy has got so many different implications, but we can manage it.
Oh, that's good. Well, the face-to-face discussion kind of leads into one of the other concerns that came up here. I may run these together, and it really goes to Kendall's point about high tech and high touch. We've got four physicians out, well, 5 of me sitting up here. talking about medicine, which is predominantly a humanistic profession that involves two people working together to solve a problem through expertise. And so what's your response to the concern that maybe new gadgets might take away from the humanity of medicine, that doctors are busy looking at graphs, gadgets, pictures on the screen, not attending to patient queues? And I mean, Kendall, you brought this up. What do you think about that? How do you guard against that?
It's interesting. I'm going to raise a little bit of the research that we did for half a minute and come right back to this question. We're looking at what is a thriving electronic community. And we found that there are three things that need to make a community thrive. How many of us sign up for an email discussion group or a website we never go back? But the three things we found is, number one, we need to be able to find e-knowledge. When we go there, we can find the things that we want to find or share the things that we want to share. Number two is e-presence, the fact that when we go there, people come back to us in a certain time. But the third is about e-trust. I think, Richard, you speak very strongly to that particular point. Without any one of those elements, your community won't thrive. And so in many ways, the trust that we talked about is that relationship. It's because of relationship. For example, I meet you, Marshall, when we graduated together, that we continue to use email communication. But that trust underpins our relationship. So in the same way, technology is going to be there, but I think there'll be a self-selection process where if we don't find the trust that we don't get, we won't be able to use it. The question is, how do we educate ourselves? How do we take part into this electronic community to build those trusts so the high touch will be there regardless of whether face-to-face or through electronic technology.
So it's not about technology, it's just about professional trust in a professional relationship, and the technology happens to be how the communication is taking place. All right, we're going to move over to the set of questions now that were generated as a result of the last panelist discussion, and we'll project that in a minute. And I'm going to take this, Lindsay, because it's a question about the organization of kind of outpatient diagnostic services. Someone says, I don't know about the figure or not, but considering that 70% or at least some large amount of outpatient radiology is performed in community imaging offices, why is there no integration of these systems into the health? In other words, how could there be communication of those results? So
the wonderful thing about technology is that I emailed my colleagues in the Health Authority when I saw that question trending. I said, because I actually don't know the answer. So they said it's about 40% of, in the Lower Mainland, for sure, outpatient radiology. And so why are they refusing? I certainly didn't get the sense that it was a refusal. I think it's a matter of priority. There are lots of things on our IT work list, and we haven't got to that one yet. That's my understanding. Certainly I'm not involved in those conversations, but I just think it's a matter of timing and priority.
I mean, you did point out that there's already the parallels. BC's been far ahead in the integration of prescribing habits through PharmaNet, has a pretty good integration of outpatient laboratory results, both private and public together, which is really just parallel to this kind of diagnostic. So it has happened in other spheres already in BC, and you're saying it's more a question of where priorities and where people, just where they're at in the process.
I believe so. We've brought community lab information into our provincial lab summary, and so it's just, I believe, a matter of timing and priority for community lab or community radiology images to come into a provincial system.
Good. There's already a fair bit of integration between health authorities. We saw some examples of teleradiology from Kendall's talk going back more than 10 years, and that was very useful, and it seems to be a pretty routine part of things. Do we think that there will be integration of actual imaging reports into like electronic medical records, both provincially and nationally? Alan or Michael, do you have any thoughts about those?
Go ahead, Michael. No, I can certainly.
Yeah, no, why don't you go?
Sure, yeah. You know, I think that we're on a journey, and part of the journey is setting the right expectation. And so integrating this information into the systems is complex, it's difficult, and it's very costly. And so I have no doubt that we will end up in a situation where the information is going to be available at the time and at the place that people need it. But as Lindsay mentioned, I think that there are a lot of competing priorities. And it's not simply a matter of just saying we're going to take a technology and we're going to link it through to an electronic medical record system, particularly when you've got a dozen different systems out there in the marketplace at the physician level. Certainly it happens much more at the hospital level, where you've got large systems that have got the digital imaging technology actually built into those particular PAC system, built into those systems directly. But I certainly think that we're on the journey. I'm sure that we're going to get there. And we need to think about it as, number one, do we need to see the images, which are very big files that have to be moved across, across the internet or across these private networks that consume a large amount of bandwidth. Some of it may just be that we don't have the roads that are big enough to actually move the data, down those particular pathways. And could the report, if we get a timely report, could that be useful sufficiently without having to actually see the image? So I'd be interested to hear what you've got to add to that, Michael.
Well, yeah, I think the challenge with looking at the list of things that we could invest in is that it's vast. It probably exceeds our IT budgets by 2 to 3 times. So somebody picked out imaging, but you could pick out a whole series of other things.
Sure.
And so, the challenge is, how do you deal with any of those issues in a timely way? I think we could all imagine that a connected image is going to be much more valuable. How many of those images that are taken in those independent clinics are repeated by the regional health authority because they don't have access to the image at the time that it's necessary? We don't know, because we don't even have some of the statistics on that. So I think this is where the policy challenge is, where we need to pick out those things that will be addressed as part of the public system, where we've got proven models. And I'm looking at the other questions here, and one of the questions relates to, why can't we do made in BC solutions? We always have to look to something that has been proven in another jurisdiction before we're prepared to fund it. Well, I think it's very wise to try to copy business models that have worked in other jurisdictions, because it lowers your risk. And particularly when you're investing public money to do that, that's a very rational and logical thing to do. But then the question is, how do you make sure that that innovative stuff is nurtured and encouraged as well? So what are the policy issues that we need to put in place, funding issues or incentive issues, governance models, to allow some of those innovative things to progress? So while we're working on the provincial agenda, which is very well thought out, but a multi-year agenda, we still have innovation happening in other parts of the health system, so that we're not all waiting on certain things to happen. It's really a matter of figuring out how to unlock other sources of capital to be able to invest in some of that infrastructure. And some of the answers actually aren't going to be very popular, because truthfully, if I take imaging, and okay, this is perhaps a dangerous thing to do, but it's the end of the day, so what the heck. It's always good to skate close to the edge to keep you on your toes. But imaging is one of the areas where technology has created huge efficiencies. Okay, where the new technology has made it much less expensive to be able to do to operate imaging operations. So maybe that, some of the connectivity should be funded by those organizations themselves. And maybe what we need to do is create an incentive structure to make sure that that is actually happening. You see that with the US model, the incentive models. They have both positive and negative aspects of the incentive. There's upfront incentives, but then if you don't adopt the technology, you see penalties where the fees that are paid by CMS will be dropping. So that, in situations where an office is not connected. So, I think those are the kinds of policy issues we're going to need to grapple with to decide which areas are going to be handled centrally and which should be allowed to innovate.
Thank you. I think we're going to wrap up with the final vote-getting question here. It's not so much the province, but I guess we've heard discussions about about the advisability or the desirability of activating patients through their use of digital technologies and taking a self-responsibility. Has anyone actually done a cost and benefit analysis on that? Kendall, are you aware of anything?
Yeah. So I think that's a very important area that absolutely need to be pursued. I think one of my colleagues come up to me and said afterwards that in our discussion, we didn't talk much about research and evaluation. I think we absolutely need to understand that philosophically, we have that understanding. The literature has suggested even before technology, activated patients save cost, save the health system activities. We have these technology that we have done research, and clearly it activates patient. And so in extrapolation, we would submit that it would lead to better saving of cost, better saving of care. But we need to demonstrate that in tangible ways, not only in terms of ways that costs get shifted. And I certainly agree with Mike. I think at the end of the day, we're not looking at, I think Richard also made that point, we're not looking at saving a lot of dollars and then you call that to apply somewhere else. But we can create a more efficient system. For example, a better way to prescribe medication, like what Al talked about, understanding the pills and reducing polypharmacy, reduce a significant amount of the budget that we can reinvest into it. And so I think the importance of evaluations, not only to understand how activated patients save costs, but how can we leverage that to shift costs into an infrastructure development, into understanding data, into how data can then be used to drive our health system care for better investment tomorrow.
Thank you very much. Well, folks, we're going to draw an end to our panel discussion. It's been really interesting, and really very much like to thank our panelists to come to speak to us today. And on behalf of the Board of Trade, we're going to load you up with some chocolate. So we'll make a presentation and invite you to have your seats, and we'll invite up our final speaker. So thank you so much, everyone.
Thank you very much.
Thank you, Lindsay. Thank you. Yeah, it was my pleasure.